Greetings from Heartcare Foundation of India and MedTalks. I am Dr. K.K. Agarwal in our series of the first digital conference in the country. And we today have another international speaker. You just heard of the president of World Medical Association. And now we have another international speaker to whom I'll interact. He is Dr. Brahm Vasudev. He is the associate professor of medicine at Transplant Nephrology Fellowship Program Director, Division of Nephrology at Medical College of Wisconsin, Milwaukee. Welcome to our show and welcome to our interaction, Brahm.
Thank you for having me.
Thank you, Brahm. With that, so the subject we are discussing is dialysis and COVID infection. In the last 48 hours, we have two hospitals who have the dialysis department shutting down. One is in South Delhi, one is in Noida. And suddenly they found that the one patient is COVID positive and they had to shut down. And probably they have forgotten that every patient in today's era is COVID positive unless proven otherwise. Like in HIV, we need to take universal precautions. We still don't have antigen antibodies test. So still we can't say that everybody come to dialysis first have to do an antibody test or a IgM, IgG test. The test is still not available. We still are in RT-PCR state and that cannot be done. So therefore, universal precautions needs to be taken. So what is unique about dialysis patient and COVID-19?
So I'll start off with saying that, dialysis population is a very unique and a vulnerable population for a multitude of reasons. First of all these patients have multiple comorbid conditions associated with their end-stage renal disease, and in general, these people are considered immunocompromised. Second thing, which is very important, is that dialysis is a life-sustaining treatment, and while social isolation may be possible option in people who are on peritoneal dialysis, it is certainly not an option in people who are on in-center hemodialysis, and these people have to come in contact with the healthcare system at least 2 to 3 times a week for their scheduled dialysis treatments. Thirdly is that dialysis unit, is a risky environment in the sense that the patients come in contact with multiple healthcare workers that work there, and they also come in contact with other dialysis patients. And therefore, if adequate precautions are not taken, viral infections can spread very rapidly within the dialysis unit. So as you mentioned that, just like you take universal precautions with people who have HIV, the dialysis units will have to take adequate precautions so that the infection does not spread within the dialysis unit.
So when we talk about a dialysis center, we also know that chronic renal disease patients are at risk of coronary artery disease, sudden death, cardiac arrhythmias, and we know that COVID-19 now causes myocarditis. And the number one cause of COVID-19 death is a cardiac involvement, and these renal patients in any way will be at a double risk, one from the kidney and second from the COVID myocarditis.
That is correct. If they get symptomatic infection, certainly, cardiac involvement, lung involvement would be a big issue in them.
So how do you think the dialysis unit in India should be doing? And what are you doing to, in your cases in Wisconsin?
So, I say that just like as doctors, we want our patients to be alert, awake, and oriented. I think the dialysis units in India need to be alert, active, and organized to deal with this pandemic. So besides, continuing to provide adequate dialysis to the patient, I think in times like this, the dialysis unit actually have additional responsibilities that include not only educating the patients and the workers in the dialysis unit, but at the same time, they need to actively partner with the physicians to protect the patients as well as the staff that works in the dialysis unit. I would say that, this pandemic has definitely put all of us in a time crunch. And one of the things that dialysis units in India can do is to not reinvent the wheel. And what they can do is that they can take policies and procedures that have already been made in some of the other countries that have dealt with this, a few weeks before, and then based on the resources that are available in India, modify these policies and procedures to suit the need uh, of the Indian population. The second question that you asked is that what are the dialysis units in United States or where I am living doing to minimize the risk of infection transmission within the dialysis unit. So I would say that there is a tremendous amount of time, effort, resources, knowledge, dedication that has gone into making policies and procedures, uh, and they've been put in place essentially to reduce the spread of viral infection within the dialysis unit. I must say that the communication between the healthcare organizations, dialysis units, and the people who work there has been phenomenal, and it includes even things like creation of dedicated websites by big dialysis providers like Fresenius and DaVita, which has answers to frequently asked questions, policy updates. They have review articles that are posted, and they also provide information about the various trials. We get daily emails from these organizations. I would say it is very similar to something that we get from your office every day. And in fact, I would like to take this opportunity and thank you and your staff for the excellent work that you guys do to disseminate scientific information throughout the medical community. Now I'll get on to some of the things that we are doing in our dialysis units here. So what we do is that before a patient enters the dialysis unit, they are checked for temperature as well as signs and symptoms of COVID-19 disease. All patients are required to put masks when they enter the dialysis unit. All the nurses, staff physicians, and other people working in the dialysis units are required to wear personal protective equipment, which includes gloves, gown, surgical masks, as well as face shields. Any patient that comes to the dialysis unit and let's say they have signs and symptoms of COVID disease, we ask them to go to the emergency room to get evaluated or tested. So we are not shutting down dialysis units. We are actually monitoring the entry point into the dialysis unit. And if they have fever or any other sign that I mentioned, we send them to the emergency room. Once they go to the ER, in the emergency room, instead of directly going to the ER, there are tents set up outside the ER where there is another set of healthcare team, doctors, nurses, who again check these people out for signs and symptoms of COVID disease. Once they are assessed in the emergency room, there are essentially three possibilities that can occur. One is that if they're not suspected of having COVID disease, and let's say the test comes back negative, they are asked to go back to their regular dialysis unit and they're cleared. Now, one of the good things is that the turnaround time now has been reduced to just about 2 hours. So patients don't have to wait for 6 hours or 10 days for the test to come back. We get the results very quickly. If the test result comes back positive, and this is very important, and if they're stable, rock stable, good blood pressures, lungs are good, their oxygen saturations are good, we send them home and tell them to quarantine themselves at home for about 2 weeks. They continue their dialysis, but they are moved from their regular dialysis unit to a special designated COVID dialysis unit where only patients with COVID go. These dedicated units offer even more protection to the workers in terms of, on top of the PPE, everybody there is wearing an N95 mask, and healthcare workers are told to minimize their contact with the patient. So, they keep safe distance. They only go close to the patient if it is needed. Now, if the dialysis patient goes to the ER and they are tested positive and they are unstable, then they are admitted to the hospital, either the floor or the ICU, depending on their condition. And then they get dialysis within that room that they are admitted. And, it could be for 2 weeks or more, depending on when they get better. We are uniformly starting all these patients on azithromycin as well as, hydroxychloroquine, in hopes that and they're in a monitored setting, so they get EKGs and all that stuff to make sure that that they're tolerating the medicines okay and they're not developing any side effects.
So a couple of out-of-box questions that when a virus enters my body, it produces an innate immunity, and then maybe 7 days later it will produce my secondary immunity, which is my acquired immunity. And in case my immunity is low, I'm immunocompromised, and my acquired immunity is late, then my innate immunity may cause inflammatory reaction, even cytokine storm. Do we see more super spreaders or more cytokine storm or encephalopathy or myocarditis in patients who are renal patients?
So, these patients who get sick, either they get pulmonary involvement, or if they get this cytokine storm, which is, more like a stage 3 of the disease, uh, in general, these patients do very poorly. They end up in the ICU. We now, in fact, have a policy that if a patient, let's say they're not dialysis patients and they get into cytokine storm, when they end up in the emergency in the ICU, they automatically, when they get intubated, before the intubation, they get a dialysis catheter as well as an A line, because we know that the incidence of AKI is very high in this population, and they would need some sort of dialysis. And many a times their lung dynamics are so bad that they have to be put in a prone position, and obviously at that time putting lines is very difficult. But we do see this small percentage of people, probably less than 5%, who get sick enough to get this cytokine storm, and as I said, they in general do very poorly.
But is there any study which talks about cytokine storm is more common in renal patients vis-a-vis non-renal patients? No.
No, to the best of my knowledge, there is no, because the number of patients are very limited, of course.
What about the role of BCG vaccination? Because people are saying in Indians, because BCG vaccination is there, and in US and European countries, primary BCG vaccination is not there. It may have been protective.
So I know there is some data that has come out, but I think that this will have to be looked back in a retrospective way at some point when there are enough number of cases to make some meaningful conclusion. One of the thing is that not everybody is being tested. So, like we are talking about this case, fatality rate and so on and so forth. But the problem is that the denominator is very uncertain. You can only talk about case fatality rate if there are 100 people, all of them are tested, and 5 of them die, and you say, well, the case, fatality rate is 5. But if the denominator is not known, then it's very difficult to make this interpretation.
What about that? We see patients on dialysis. They because their creatinine level is near normal, and they can be on ACE inhibitors or ARBs. Now there is a controversy about ACE2. One study says that ACE2 will prevent a cytokine storm. Another one says if there are more ACE2 receptors, there are more chances of going into a complication. What are your stand?
Yeah, so many dialysis patients, if they are already on dialysis, generally their creatinines are not normal. Their creatinines are very high.
5.
Second thing is that ACE inhibitors are very weak antihypertensive agents,
In
and in in general, so not a lot of dialysis patients are on it. And the third problem is that ACE inhibitors are dialyzable. That's why we don't put
don't
a
use
lot of is. So therefore, it will be a little controversial. And again, as I said, the problem is numbers. We don't have a lot of dialysis patients to make any meaningful conclusion as of yet.
What is your personal opinion when you will be able to visit back to India? Means when there will be a lockdown out in India and other countries? When will the
Oh, probably,
international travel start? Personal
ho-
opinion.
hopefully this summer.
Hopefully this summer. So you are a believer that this droplets will dry out much faster in a humid and summer atmosphere.
Some of the data that I have looked at, like their cases in, let's say, Brazil, and it's pretty warm there right now. So there is some data that the humidity and the temperature increase may not have as much effect as we think. But what I do believe is that, this concept of social isolation, which is going to flatten the curve over a period of time, and if we are able to have enough herd immunity, let's say 60% of the population at some point is immune, I think the spread will really become less. And I think that would be the principal driver.
So the R value is 2.5. So we will require 40% of the population getting herd immunity. And that was the reason when the UK said that why not have all the younger people getting infected. And that was criticized. So they had to withdraw their statement at that particular moment.
Right, because younger people will end up infecting older people at home and so on and so forth. So that was one of the big problems.
Any personal, have you read anything about why people become super spreaders? Some people are super spreaders, and people like Kareena Kapoor, a film actress, who went around meeting hundreds of people and she did not infect even a single person. On the contrary, there are one person who will infect so many people. So, like we have HIV positive versus HIV plus gonorrhea positive. HIV plus gonorrhea is much more infectious than HIV positive alone. So,
Right.
find out, we all are looking for this answer, what makes a person super spreader. And if we do that, and we are exchanging notes from everybody in every part of the universe, let's all concentrate on what makes a person super spreader, and that may be the answer.
Right. And again, the big issue is that good number of patients just have very mild symptoms. They don't get sick enough to the point of even wanting to go to the emergency room and get tested. So it is a little difficult to interpret if everybody is not being tested.
So tell us the 10 points which every doctor should know as far as dialysis, transplant, and kidney is concerned. 10 take home messages.
10 take home messages. Okay, so I'll start off with dialysis first. We'll touch a little bit about transplant after that. So one thing I would say is that the doctors are definitely in line of fire with this pandemic. It's almost like a war, except at this time, instead of regular soldiers, it's the doctors that are fighting. And just like when there is a war, the soldiers don't run away from the war. I think the doctors need to stay put and understand that they are very important in this process. So like you mentioned that some places have closed down the dialysis unit. I don't think that's a good thing to do, because you know it's a life sustaining treatment for dialysis patients. I think one of the things that the doctors should do is they should definitely minimize contact with COVID patients. So one of the things that we are doing here is that if somebody is proven to be COVID positive, they're not 10 doctors and 10 nurses going into the room and examining the patient, every couple of hours. There is one doctor who examines the patient in the morning, and then we go by that physical exam. So one can minimize contact so that your chances of catching the disease is less. The third thing that the doctors can do, I think, is that they can, if they have not already started, I think they should start televisits or virtual visits, so that patients don't have to come to the hospital or healthcare environment and get sick. Another thing that I would say is that the doctors should definitely be on top of whatever scientific data is available to help them understand this disease. If there is newer treatments that are coming, the physicians really need to be on top of the game at this point. uh, in terms of transplant, what we are doing is that because they are immunocompromised, and if they catch the disease, you're right, the disease can be much worse in them. We are really stressing on social isolation in these patients. Even if they're at home, we tell them don't even go to the grocery store, send somebody else, and you stay within the house. Uh, and if they are symptomatic, we tell them if they have fever, they should call us right away. The FDA has approved now antibody test for COVID, and this occurred, I think, within the last day or two. And one of the things that is being proposed is that maybe healthcare environment can check people who are working in a hospital for IgG, IgM, and if they have some protective antibodies, maybe those people can be ahead in the line of fire and keep away people who are not immune.
And even
Another
those people who have been treated, who even if they are non-doctors, all those people who are treated can be the frontline warriors.
Right, that is correct. Another thing that we have done here for doctors is that, if people are at least in our institution, that's the policy that they've made, that if somebody is more than 60 years of age, we are telling them to avoid coming to work. And a lot of us people who are, less than 50, we are picking up the work from doctors who are older so that they can stay at home, because if they get sick, obviously their mortality is higher than people who are younger.
My last question to you is that we do know that COVID doesn't transmit via blood transfusion because viremia is very less, though we still don't know the answer. What about reusing the dialyzers in COVID-19 situation?
I do not see any problem in reusing, because, when we reuse these dialyzers, a dialyzer is allotted to a patient. It's not that it goes from patient A and reused in patient B. So as long as it is their own dialyzer, there is really no problem at all with reusing dialyzers, as long as the standard precautions are taken.
Well, the time doesn't permit me to go further because we have two more lectures. This is the first digital conference we organize, and it is 16 lectures at a go. A conference where there is no tea break, no lunch break. We are continuously organizing it. I am continuously moderating the sessions. It's a unique experience. Thank you being with us. And we will love to have you with many more such sessions which are specific to transplant and other things. Thank you very
Sure.
much for being with us.
Thank you for having me. Take care. Stay safe.
Thank you.